In view of the second MBBS practical exam, which begins in less than 36 hours from now, I thought I'll make a video on the difficult aspect of pathology practical exam, which is the spotters. In spotters, we have 10, so each carries 2 marks, so the total marks carried by spotters would be 20. And in this, out of the 10 spotters, we have 5 slides, 4 specimens, and 1 instrument. Usually, students do well on this specimens and instrument, but they find these slides challenging because you have to look into the microscope, and sometimes looking into the microscope and diagnosing slides is not that easy. So that is where people find it challenging. And these 5 slides will get 3 histo and 2 hemat. So the purpose of doing this video is to give some confidence to the students before they go to the exam so that they can answer these slides a little better. Now, considering the weightage of practical exam from the batch of 2K21, wherein this marks are also being added to theory, I think it's a good thing to do well on the spotters, because 20 marks, so that is about 20% of your practical exam. And if you do this well, you are paced to do very well on the practical exam as a whole. When I was in my second year, when I was going to do the slides, I thought that someone would help me with the slides. I had absolutely no idea what the slides were and how to diagnose them. I think a lot of us feel that way because we feel that the microscopy, etc., is basically very bad and we can't really diagnose it. So I thought someone would help me, and I went to the exam, and I found out that no one was there to help. So I was just standing there completely by myself, surrounding everyone who were writing the answer, and I lost all the marks. So anyway, so we'll do these slides one by one and we'll try to understand how it is. So the major stain that we use, first we'll talk about the stain, then we can go back. I think everyone knows that the stain that we use in histology is HND, which is hematoxylin and eosin. Now if sky is blue, then in our histology, nucleus is blue, whereas the cytoplasm is pink. If we know these things, we can get going. So nucleus is blue in color, whereas cytoplasm is pink in color. Now, we'll go to the first slide. I've started this with the most easiest slide, I think, out of the lot. This is the most easiest slide, which is, we can see here, there are some cells, large cells which don't have anything, they don't have a color at all. And what are these cells? So if you're thinking that the answer is lipoma, you're right. So what you see here is a bunch of adipocytes, and these adipocytes are like this. Now, why are these adipocytes clear? Because you know that in an adipocyte, in a mature adipocyte, the growing fat bubble, if you imagine this is the fat bubble, it will push the nucleus to the periphery. So if it is pushing the nucleus to the periphery, we just have fat here. And the thing about fat is not taken up by the HND stain. So that is why it is staining, not at all staining inside. So it is looking white. So this is an adipocyte. This is our mature adipocytes. And the answer for this would be lipoma. Now, sometimes some people, with the second slide, if we go to that, people get confused among this first slide and second slide, that is lipoma, and the second slide. See, the second slide also, it has aspects of fat. It also has some white bubbles inside. So this also means this was not stained. This was not stained by the HND. Now, this diagnosis would be fatty liver. So these are hepatocytes which contain fat. So the diagnosis of number 2 would be fatty liver, whereas 1 would be lipoma. Now, if I compare these two things once again, so on the left, it would be lipoma. We have adipocytes, which are very big, nice, and they are designed to store fat. That is why they're larger when compared to the right side, wherein we have hepatocytes. Because of conditions such as alcoholism and all, they start storing fat, and they are normally not used to storing fat. That is why you see all this fatty change. So this is the fatty change, which is the first stage that occurs with alcoholism, and there are other reasons why you can get fatty liver as well. So on the left it is lipoma, on the right it is hepatocyte. You see a lot of pink in the hepatocyte when compared to the lipoma, wherein it is mostly white. Now slide number 3, let's go to one more slide which has some fat. So as you can see, all these white bubbles are fat. So on one side you have all this fat, etc. So if you're thinking that this answer is something related to the salivary gland, you're right, because this aspect, the left side of the slide, is normal salivary gland. So normal salivary glands also have some intrasalivary glandular adipose tissue. So on the right side, this new picture is actually the normal histology of a salivary gland, wherein we can see a lot of fat adipocyte deposition as well. Then we have these things, the starry looking things, and these are called as the acini. These are the acini of the salivary gland which produce the salivary secretions, whereas these are the ducts. So obviously the salivary secretions should be brought to the buccal cavity. So these are called as the ducts and the acini. So on the left side we have a normal histology which is showing the salivary gland for you to diagnose that the organ which is inside is a salivary gland. Whereas on the right half of the slide has the tumor itself. So this is the tumor, and if you're thinking about the answer would be pleomorphic adenoma. It's a very important question for your normal theory exam as well. So pleomorphic adenoma, wherein it is like that, it is very blue because we call something called as a chondromyxoid stroma. So when you get this, you can see normal adipose tissue. On the right, you see pleomorphic adenoma, which is showing chondromyxoid stroma. It is called pleomorphic because it is actually made up of two components. One is the epithelial component and the other one is the stromal component. So it is one tumor which shows two components, one epithelial and one stromal. The stromal component is in a very distinct pattern called as chondromyxoid stroma. That is why we get the blue thing. Chondro stands for cartilage. So cartilage, hyaline cartilage, etc. When you look at it, it's very blue, right? So that is why it is called as a chondromyxoid stroma. So the answer for this one would be pleomorphic adenoma. So moving on, we'll go to some slides which have to do something to do with blood vessels. There are some tumors related to blood vessels and there are also non-tumors as well, as we just go through. So now I always talk in the class about how a blood vessel is a pipe, right? So it's a pipe which carries blood. So inside it has blood. Now if we cut this blood vessel and if we look at the cross section, if you are looking from this side, it will look like a round, right? So inside it has blood, etc., whatever. So inside we have blood, and this is the cross section of a blood vessel. Now we know there are different types of blood vessels. There are arteries. So when heart pumps out blood, it pumps into the aorta, and from the aorta it goes to the arteries, and the arteries, they become small, called as arterioles, and eventually they become very small, which are called as capillaries, and these capillaries then will form veins, and these veins will bring the blood back to the heart. So that is the normal idea of how a blood vessel looks like. So if you take a cross section of a blood vessel, we'll see it under the microscope, it will look round. So I'll just show you a picture of this. So once again we can see this is one, the whole thing, and we also can see there is one more here, which are actually blood vessels. And now this blood vessel, when compared to this blood vessel and this blood vessel, we can see that this area of this blood vessel is rather thicker. So what do you think this blood vessel is? This blood vessel is probably an artery, because arteries have thick muscle when compared to the vein. So tunica media of the artery, you know that there are three layers of the blood vessels, right? So innermost part is called as a tunica intima. The middle one is called as a tunica media, whereas the outer one is called as tunica adventitia. So here we can see there are two blood vessels. One blood vessel is much thicker in the media region. That is the artery, because arteries have thick smooth muscle, and that is why it is harder for the arteries to collapse when compared to the veins, whereas veins, they don't have as much tunica media when compared to the artery. So this would be an artery and a vein. Now we'll see the first thing in blood vessel, pathology in blood vessel. Now here in this number 4, we can see a lot of small blood vessels. So as I told you before, when you take a cut section of a blood vessel, if you take a cross section, it look like a round. And there are some things here as well. These are longitudinal sections, so they don't exactly look like round. Even this one. So how do we know that these are blood vessels? So firstly, they are round, and number 2, if you look inside, can you see these red dots? I don't know if the clarity is coming up, so I advise you to put it at the highest quality available. But inside you can see these little red dots. These little red dots are actually the blood, the RBCs, okay, which are there in the blood. So now you see there is a tumor which is containing a lot of this small blood vessels, and there is some blood as well inside these things. So what is the answer of this? What are the smallest blood vessels called? They're called as capillaries. So the diagnosis of this would become capillary hemangioma. Hemangioma, because oma is benign tumor, angio is vessel, heme is blood. So blood vessel, benign tumor of the blood vessel, and because it is forming small blood vessels, it is called as capillary hemangioma. So it's an easy slide to diagnose. When you look at it, you see a lot of this round things, and inside that you can see some blood. So the answer of this would become capillary hemangioma. So moving on, we'll go to the 5th. I exactly couldn't find the slide that you have, but it's an easy slide as well, wherein you see instead of finding small blood vessels, you will find a lot of big vascular channels. So these are all big channels you will see, and inside this you'll see blood. So all these red dots are blood. So there are some WBC, but most of them you see a lot of RBC, which are red in color. So you have this cavernous big sinuses like things, and inside that you see a lot of RBC. So that is why this one is called as cavernous hemangioma. So cavernous because if you remember your first year, you have studied about cavernous sinuses, right? So these are large channels. So it looks like that. That is why the large channels, they have called it cavernous hemangioma, because these are big dilated vascular spaces which have a lot of RBC inside. So there are two patterns of hemangioma that you get. If the endothelial cells, they form small blood vessels, we call it capillary hemangioma. When they form this large vascular channels, we call them cavernous hemangioma. Moving on to 6. So now there are some blood vessels, can you see? So this is one blood vessel, 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 and this is one blood vessel. Now, if I ask you a question, do you think are these arteries or veins? I'll give you 2 seconds to think about it. Are these arteries or veins? If you're thinking that these are arteries, you're absolutely right, because the tunica media, can you see? It's very prominent here. So here as well, the tunica media is very prominent. So now what do we think this is? What is the diagnosis of this? So these blood vessel looks normal, this looks normal, this looks normal, this looks normal. Whereas right here, we can see that there is something inside, it is looking in a bluish and purplish. I don't know if purplish is a word, but you can see some material which has been deposited in the tunica media. So the diagnosis of this would be, this is actually the deposition is of calcium. So calcium is getting deposited. Calcium will have this kind of a purple-like appearance, purple bluish appearance, and that is calcium. So what is the diagnosis of this? It is called as Monckeberg medial arteriosclerosis, or you can just write Monckeberg arteriosclerosis. But the idea is Monckeberg medial because it is there in the tunica media, and arteriosclerosis because there is deposition of calcium that is making it hard. Do you think it will affect the lumen of the blood vessel? Do you think it will affect the blood flow? So if you're thinking no, then you're right, because it is not affecting the intima layer. The intima layer is still fine. So the blood vessels are not affected at all. I mean, you can still have the same amount of flow, whereas it is only there in the tunica media. That is why it is called as Monckeberg medial arteriosclerosis. The word itself is a mouthful, Monckeberg and all. It reminds me of a meme, it's called Reject Humanity, Return to Monkey. Monckeberg, right? Okay, I know, stupid meme, but let's go back to number 7. Well, in this, the slide which we have for the exam is not very good. I don't know if they'll put this slide or they'll change this slide. Just pray that you don't get this slide. So this slide, when you look at it, you can also see there are a lot of small blood vessels which are there. And apart from the blood vessels, can you see there is a lot of dots, a lot of blue dots that you see all around. So this is one blood vessel, see, very small blood vessel, very small blood vessel, very small blood vessel, very small blood vessel. Whereas you have a lot of these blue dots, and there is also a lot of pink. All this pink is there, and in the midst of the pink you see a lot of blue dots. Well, if you're thinking, well, why it is looking like this, the answer of this would be granulation tissue. I'll just show you in a while a normal picture of granulation tissue. So it'll just pop up. So anyway, so this is granulation tissue. Now granulation tissue, where do you see? Granulation tissue is the hallmark of wound healing. If someone has a wound and it is healing properly, these people will contain a healthy granulation tissue, which is laying down the matrix to make more tissue. So obviously when you have a wound, you have to heal this wound. So that healing is done, and one of the first steps of the healing is the body forming something called as a granulation tissue. So let's say you want to form a new tissue at the site of damage. You need blood there, so the body will form a lot of this smaller blood vessels. So if you see a normal diagram, you see a lot of smaller blood vessels which are kind of leaky. So that is why all the inflammatory cells, they come outside. All the WBC, you can see lymphocytes, you can see eosinophils, you can see neutrophils, all those things which come outside. And then you also see, especially, what is this pink thing is, these are all fibroblasts. So there are 3 aspects of granulation tissue. Number 1 is you see blood vessels. Number 2, you see inflammatory cells. And number 3, you see a lot of fibroblasts which are laying down collagen, because collagen is the major component of granulation tissue, and later on in the tissue, and the type 3 collagen especially comes here in granulation tissue. I remember it as granulation tissue, granulation tissue. So 3 for collagen type 3. So that is what you see. So hopefully, I don't think, I can't be sure of anything, but if you get this, then you are little hard to diagnose, but just pray that you don't get this slide, which is granulation tissue. And even if you get it, you can just write about it. This is granulation tissue, and you can write all the 3 aspects of granulation tissue, which are the blood vessels, inflammatory cells, and fibroblasts, which are laying down the collagen. Now, there are also some slides related to the skin. So I'll just go through normal histology of the skin so that we can just go to the slides which are there in the skin. Now we know that skin has two parts. The outermost part is called as the epidermis, whereas the inner part is called as the dermis. Now epidermis is lined by an epithelium which is called stratified squamous epithelium. Stratified because there are multiple layers. As you can see, there is one layer like that. There are multiple layers and it is squamous epithelium. So all these cells are squamous cells. And the bottommost part of the epithelium is called as a stratum basale. So these cells, if we just look at it once again, so till here these are the squamous cells, whereas these are the basal cells. So squamous cells are there and basal cells are there. What is the function of these basal cells? If you see basal cells at the bottom of the stratified squamous epithelium, they are very blue in color when compared to the outside things. I mean, if you see at the top and if you see at the bottom, if you compare this cell to this cell, you can see that the basal cells are very blue. Why do you think they are blue? Before I told you, right? So why is the nucleus blue? Because of hematoxylin. So if there is more DNA, more nuclear thing, it will be more bluer. Whereas the top things, they don't contain that much DNA when compared to the bottom. That is why the bottom areas are more bluer. The reason for this is, what is the stem cell? See, we know that skin is there. Skin, the top layer is dead. The cornea is dead. So every time what happens is, we call it something called as a turnover. That is, the basal cells, they are the stem cells. They are the ones which are dividing and they are making new cells. And these cells will go up like that and eventually they die. So we have new cells getting produced every day in the skin, and this production is done by the stratum basale. Because stratum basale is dividing, that dividing cells should contain more nuclear material for allowing them to divide, and that is why they are more blue in color when compared to other things. So in the epidermis, we have squamous cells, we have basal cells, and what other cells do we have? So once again, if I write them, we have squamous cells, which are formed by the basal cells, which are there at the bottommost layer. And what is the other type of cell in this epidermis? So there is one more type which is called as a melanocyte. Melanocytes also usually reside near the basal layer, but there is also, they're distinctive from the other types of the cells that we see in the skin. They're called as the melanocytes, which produce the pigment melanin, which is responsible for the pigmentation of our skin. So now, if there are three cells, there can be problem with these three. So if you get a tumor from the squamous epithelium, if you get a malignant tumor, it is called as squamous cell carcinoma. If you get a tumor from the basal epithelium, it is called as the basal cell carcinoma. And if you get a tumor from the melanocyte, if you get a malignant tumor from the melanocyte, it is called as melanoma. It is called as malignant melanoma. So OMA it's an exception, because normally when we think about OMA, we think it is benign, but malignant melanoma is an exception, wherein the name is melanoma, but it is very malignant tumor of the melanocytes. So you have SCC, you have BCC, and you have melanoma, squamous cell carcinoma, basal cell carcinoma, and melanoma. So now we'll go to the first thing in the skin. Now anyway, if you see this, it looks kind of hazy. I don't think you are seeing a lot. You are seeing maybe this is all the tumor tissue. I'll only tell you that this is all the tumor tissue. The answer for this is squamous cell carcinoma. Now how do I know that this is squamous cell carcinoma? Is there are some features inside that you need to see. I'll show you another slide as well, but can you see this in the middle? There is a little like this area. So this area is actually called as a keratin pearl. We know that normally squamous cells, they produce keratin. So that is why we have stratified squamous keratinized epithelium. So they normally produce keratin, and because these cells are dividing very differently, I mean, they're all not in synchronous to each other, they'll produce these little concentric areas such as called as keratin pearls. I'll show you another picture which is showing keratin pearls. So this is one keratin pearl, this is one keratin pearl. These are all the tumor tissue. These are all tumor squamous cells. These are all malignant squamous cells which are entering the dermis, because obviously a malignant tumor will infiltrate the underlying stroma. So that is why they are coming in from the epidermis into the dermis. And see, we have nice formation of this keratin pearls, and the answer for this would be squamous cell carcinoma. So here as well, we can see that this is another picture. This is not from your slide, from just a book, so that I can show you how this keratin pearls work. So all these tumor cells, they're forming these round structures which are called as the keratin pearls. So keratin pearls are an ideal thing that we see with well differentiated squamous cell carcinoma. So whenever you see this keratin pearls, write the answer as squamous cell carcinoma. Now moving on, one of the easier slides again. So number 9, this would be something called, see how are the cells firstly. When you see the cells, so I'll only tell you that these are the tumor cells. Now all these blue looking cells, they are the tumor cells which have left the epidermis and they have come into the dermis. So in the middle you have the dermis, the pink thing is the dermis, whereas these blue things are the tumor. Now, what color they are? When you look at this tumor, what color are these cells are? They're strikingly blue. So why are they strikingly blue? What cell is strikingly blue in an epidermis? That's the basal cell, right? So when we talked about basal cell, I told you that basal cell is the one which is dividing and producing new squamous cells. So that is why it has more DNA in it, because it is always doubling its DNA so that it can divide, and that is why it is blue in color. Now, if you get a tumor from the basal cell, the basal cell will also look, the tumor basal cell will also look this blue color. So the answer of this would be basal cell carcinoma. There are some features, there are two features of basal cell carcinoma that helps you to diagnose. So one thing is, let's imagine, I'll just draw a little diagram showing you that, imagine that this is a basal cell carcinoma. So imagine this is the dermis. So all surrounding area is the dermis because it has infiltrated into dermis. Let's imagine this is all the dermis. And this part is the basal cell carcinoma. So when we make this histopathology slide, so when we do all this staining, etc., we have to put it in wax, we have to take it out of the wax, then we have to cut the tissue and all. So during this process, what happens is there is a lot of alcohol which is also used for the dehydration of the tissue, etc., so that it won't interfere in our ability to stain. So what happens as a result, sometimes these nests, we call them nest, this part of the thing we call it nest. So sometimes what happens is, if this is the dermis, once again, the surrounding area of the dermis, these nests can actually shrink. This nest of the basal cells can actually shrink. So that's what exactly that we are saying. That is, there is some gap, right, between the dermis and the nest. That is because of the processing that we do for us to get this right. So that is why this white gap between the nests is called as a retraction artifact. So you can write in the exam that you are seeing nests of basaloid cells which are showing something called as retraction artifact, and this retraction is because of processing which been undertaken during the production of the slide. And then you also have one more thing. If you see the periphery of these things, see the surrounding area in the nest itself, if you see the surrounding area looks more darker when compared to the middle area. It looks more streamlined when compared to the middle area. That is because inside a nest, inside the nest of the basal cell carcinoma, the most peripheral side, it will be like this in this direction, whereas in the middle it will be like this. So that is why they are more, you can see them in a better way. This is called as peripheral palisading. So there are two features of basal cell carcinoma. One is the retraction artifact, basaloid cells forming nests with a retraction artifact. Other one is something called as peripheral palisading. Palisading because all the things are arranged in this direction, whereas only this thing, they are arranged in the palisading wall-like pattern. So that is why they look distinct when compared, because they are in one direction when compared to the other things which are there in the middle. So this is called as basal cell carcinoma. Now slide number 10. Once again, if you can make out, this is the epidermis. The topmost layer is the stratum corneum, which is dead. So this is the epidermis that is there. Now in the dermis, we can see there is a lot of some tumor tissue here. Now in the tumor tissue, very distinctively, it's an easy slide if you see that, we can see a lot of this brown pigment. Now there is tumor tissue which is showing this brown pigment. Now what is this brown pigment? It is melanin. So what is the diagnosis of this? This would be melanoma. Okay, melanoma is never benign. Melanoma is always malignant. That is why it is called as malignant melanoma. So the diagnosis of number 10 would be malignant melanoma. So we have finished the three things of skin. One is the squamous cell carcinoma, one is the basal cell carcinoma, one is the malignant melanoma. Now there are two slides related to necrosis. So what is necrosis? So when we talked about necrosis, I think you all must have studied it for the theory exam as well. Necrosis is death of cell. So when a cell dies, it can be either apoptosis or necrosis. If it dies in a programmed fashion, it is called as apoptosis. Whereas if it dies because of an accidental cause, for example, someone has hypoxia, someone has ischemia leading to hypoxia, the cell death can happen. This is called as necrosis. Now, what is the hallmark of cell death? I ask this question all the time. When a cell dies, what is the first thing which it loses? That is the nucleus. If you're thinking it is nucleus, you're right. So the hallmark of cell death is loss of nucleus. So there is the nucleus which is lost. Now, when we talked about the first slide, I told you inside a cell, we have a nucleus and the cytoplasm. I told you cytoplasm is pink, whereas nucleus is blue. Now we are saying that the nucleus is not there. Right, so when in necrosis, the first thing to go away is called as the nucleus. So if the blue goes away, what remains? So pink remains. So necrotic tissue looks pink when compared to the non-necrotic tissue, because necrotic tissue has lost the blue. So the only thing it has is pink. So we'll see just in a while. Don't worry about it, because the next two slides, they're very nicely, we can say that they're pink because there is loss of nucleus. Now, So slide number 11. So just see them and let's think what this is first. Well, let's try to understand what this is first, then we can talk. Can you see these long fibers which are going, long bundles, like all these bundles of something? Does it look like muscle? If you're thinking it is muscle, then you're right, absolutely, because this is actually the cardiac muscle. So normally cardiac muscles will look like this. So just a normal reference diagram. This is your exam diagram. Now anyway, if we look at this, can we see the nucleus inside? Obviously cardiac myocytes have nucleus inside. But when you compare this to this, can we see any nucleus inside? We don't see any nucleus inside. So here, we don't see any nucleus properly, even though some are there, they are very faded out when compared to this side. That is because this is an example of myocardial infarction. The diagnosis of this would be myocardial infarction. Because you remember, whenever any tissue undergoes infarction except the brain, they all undergo a diagnosis which is called as coagulative necrosis. So this is an example of coagulative necrosis because of myocardial infarction. Now what is the hallmark of coagulative necrosis is, see, for example, this is a cell which has a nucleus, and let's say it has undergone infarction, it has died, and it has undergone coagulative necrosis. You will see like this. So that is, the nucleus is absent, whereas the cell borders are still maintained. So this is a hallmark of coagulative necrosis. That is, you can still make out that these are all muscle bundles, but you don't see nucleus inside. So cell borders are there, but the nucleus is not there. So this is called as coagulative necrosis. And one of the very classic examples of coagulative necrosis is myocardial infarction. So moving on, we have another diagram as well here. That is, see, very classically, we can see this area of pink here, and we can see this area of pink here. And you see a lot of these blue little dots. So what is blue in color? What are these little dots which are blue in color? I mean, in first year, I think you must have studied about lymphocytes. Lymphocytes have a scanty cytoplasm. So all these blue dots are lymphocytes. Now, where do we see a lot of lymphocytic collection in a tissue? This is probably a lymphoid organ. So let's call it a lymph node. A lymph node is a lymphoid organ. It's a primary lymphoid organ which contains a lot of lymphocytes. And inside these lymphocytes are blue in color. So that is why you see a lot of this blue which is there. Now, what about this pink? This pink represents necrosis. So this is one area of necrosis, whereas this is one area of necrosis. Now, what is the necrosis that we see in a lymph node more commonly? Is because of infection, and here the answer is tuberculous lymph node. When you have TB lymph node, we get something like this. And when TB lymph node is there, what is the classic thing of tuberculosis is it causes something called as caseous necrosis. So you can write this whenever if you get this slide, you can either write it as caseous necrosis, or you can either write it as, don't write it TB lymph node, you write it as chronic granulomatous lymphadenitis. Okay, chronic granulomatous. TB causes chronic granulomatous lymphadenitis, which is caseating. So you can either write it as caseous necrosis or write it as chronic granulomatous lymphadenitis. Both of them are right, and you'll get the marks. So now, what are the classic features? I mean, even though the slide will be focused like this, I'm just asking what is the features of a necrosis. So in the middle you have necrosis, which is surrounded by areas of what are the cells of caseating granulomas. Have you heard of the cells which are called as epithelioid cells, which are modified macrophages? So these are the epithelioid cells. I'll just show you in high power as well. So when you see, this is the necrosis, this part is the necrosis, this is the lymphocytes, this is the normal lymphocytes. So in the middle we have necrosis, and surrounded by it, see, there's some lymphocytes are there anyway. So you can see a lot of spindle shaped cells here. Say for example, this one is a very nice spindle shaped cell. So these spindle shaped cells are the epithelioid cells. So these are the epithelioid cells, and some of these epithelioid cells, they fuse to form a giant cell. So this is one big, very nice giant cell wherein the nuclei are there towards the periphery. That is why these are called like a horseshoe shaped. So you call it a Langhans giant cell. A Langhans giant cell which contains this horseshoe pattern of nucleus which are getting deposited into it. So multiple cells, they fuse to form this Langhans giant cell, which are giant cells which contain nucleus to the periphery. That is why they're called as horseshoe shaped. So you have fibroblast, you have lymphocytes, and you also have these things which are Langhans giant cell with the central area of necrosis. So this is caseous necrosis, or you can also write in the exam as chronic granulomatous lymphadenitis. Please don't write it as TB lymph node, because some people don't really like writing it as TB lymph node. Now we have finished the skin, we have finished the necrosis part. Let's come to the gland part. Now, any gland in your body, let's imagine your salivary gland. Previously we have talked about salivary gland. That is, any gland has something called as an acini. I'll just briefly draw a diagram to how these glands usually work. So that is, these glands usually have few cells in the middle. These are called as the acini. So the function of this acini is to secrete. The function of this acini is to secrete whatever fluids that they are secreting. For example, the salivary glands, they secrete saliva. For example, the exocrine pancreas, they secrete the digestive juices such as the lipases and the amylases, etc. Proteases as well. So now these are getting secreted. So the exocrine glands, they send their secretion to one specific point. For example, salivary glands, they send their secretion to the buccal mucosa, whereas the exocrine pancreas will send their secretions to the duodenum. So there is one other part of the gland which takes the secretions from the acini into the area which is needed. For example, buccal cavity in the case of salivary gland, as I told you. So this part is also lined by some cells. These are usually columnar cells, and this part of the gland is called as a duct. So you have two aspects of a gland. One is the acini and one is the duct. So once again, the same thing. These are also like pipes. So whenever you take a cross section of the pipe, they will look like a round. So based in mind, we'll just talk about what are the things that we see in the glands. So now number one, this is a very easy slide as well. So we can see that these are all glands. I told you, right? So the glands usually look like round whenever you take the cross section which contains these cells, which they can be duct, they can be acini, but these are the lining cells which are there, and in the middle there is empty because it may contain secretion, but that's about it. It will also look like a round. Now, before the answer of this would be, if you're thinking it as fibroadenoma of the breast, then you're right. So the diagnosis of this would be fibroadenoma of breast. So I'll just explain this fibroadenoma because sometimes I think some people find it challenging, that fibroadenoma of breast, and what are the findings. So why are we seeing some glands like this and some are we seeing small glands, we are seeing some larger ducts like this. So let's talk about this now. So previously, as I told you, let's imagine a mammary gland. A mammary gland is the breast, right? So in the breast as well, we have the same concept. That is, we have some cells which produce. In the mammary gland, it produces milk. So you have mammary gland which is producing milk, and this milk is then carried out by the duct. So you have the acini and you have the duct. So these acini in the breast, we call it a lobule. So lobule part is the one which contains this acini, and it is getting transferred by the duct, and ultimately all these ducts, they reach the nipple areola region. Alright, so you have multiple ducts, you have multiple acini, multiple ducts, and they all eventually, they all lead to the nipple. All the ducts, they lead to the nipple. Now what is there in between this acini and duct? So this acini ductular unit is there, this lobule duct is there, this lobule duct is there. What is there in the middle of these things? They are not just floating in the air, right? So in the middle we have something called a stroma. So stroma is the one, connective tissue, blood vessels, fibrous tissue, physical support, all that support is provided by the stroma. So you have these components which contains the epithelium. The glandular component is the one which is containing epithelium, whereas in the middle of this ductal units you have something called as a stroma. Well, now once again I told you that the ducts are like pipes, so they are like pipe. And then if you look at the pipe from one cross section, if you take the cross section and see, they'll look like a round. So now let's see what happens in fibroadenoma. So the name itself tells you that it has some fibrous in it. So normally fibroadenoma is actually a stromal tumor. So that is what they think, that it is a stromal tumor. So now let's imagine, I'll just draw some cross sections of the ducts. So let's imagine these are the ducts. So what is there in the middle? In the middle of them you have the stroma. So in the middle of these ducts you have stroma, and fibroadenoma is the stromal tumor. So whenever a tumor is forming, the tumor will eventually start to divide. The tumor will try to grow. So as the tumor grows and grows and grows. Now let us draw this again. Now let's imagine this is the duct, and I told you that the tumor is in the stroma. So stroma is the one which is surrounding. So now let's imagine if the stroma is actually pushing in on the duct. So obviously if it is growing, it doesn't have much space, and so it can sometimes also come and compress this duct. So this round duct, when it is getting compressed from either side, it will become something like this. It will become a little elongated and it will become very narrow. So this is called as a slit. The slit, I think we have studied in physics as well, right? So back in 11th and 12th we studied about ray optics, wherein you see the slit. Slit is a very tiny opening, so it will look something like this. So this is a slit, and this is the duct which is the compression of the duct which is leading to the formation of the slit, and this pattern is called as intracanalicular pattern. There is one more pattern as well, wherein if this is the duct and the growing stroma is there, the stroma grows around the duct and it will not disturb the duct. And that is, in this, the duct is not compressed, and these are called as a pericanalicular pattern. I don't want to go into so many details, but the idea is if we see this, we can see there are some ducts which are looking normal rounds, whereas some ducts which are looking very much elongated, very and narrow. When we compare to the round things, these are kind of narrow and they are very elongated. And these things are called as the intracanalicular pattern. So you see both pericanalicular pattern and intracanalicular pattern, and the diagnosis of this would be a fibroadenoma of the breast. So it's a tumor tissue which contains both the fibrous and adenomatous component. That is, this is the fibrous tissue, this is the glands, and in the glands we see both type of patterns. You have some collapsed compressed ducts which are called as intracanalicular pattern, and the normal ducts which are called as the pericanalicular pattern. So now we'll go back to number 14. So this is the slide which is number 14. Now once again in this slide, if you can see, can you make out all these ducts, all these glands? So these are all the glands which are there. And these glands, if you can see little bubbles here, little white bubbles. So all these glands will have little white bubbles. Now you tell me which glands contains this white bubbles. Can we call them goblet cells? So where do you see goblet cells in the intestine? So this is an example of colon, wherein we see at this part of the slide. So if we draw this, at this part, all these things are the benign mucous glands. So you know that there are different aspects of a wall of the intestine. You have mucosa, submucosa, muscularis and serosa. So we are in the mucosa, and in the mucosa we are seeing a lot of these mucous cells. Now when we compare these glands to these glands here, they're looking very big, they're looking very dark, they're looking very different. So this is the tumor of the glands in the colon. So what is the diagnosis? The diagnosis of this would be adenocarcinoma. These are malignant. They're called as adenocarcinoma because see these tumor cells as well. They are also forming round structures. Even though they're very different than normal, they're bigger. Obviously when we study about malignant, we study that there is increased NC ratio, etc. because these tumors are dividing very rapidly. So that is why they're still forming these glands. That is why they're called as adeno, and it is carcinoma because the glands contain epithelium. So we know that the tumors of the epithelium, malignant tumors of the epithelium, are called as carcinoma. So the diagnosis of this would be adenocarcinoma. When they focus, they'll normally keep the glands as well, the normal glands. So you see that, you identify the goblet cells, you see that this is the colon, and then you also see the tumor tissue, which is the adenocarcinoma. This is the normal, ducts that you see in the colon. As I talked about, these are the goblet cells. So that is what we are seeing here. So the right side of the slide is the normal component, whereas the left side of the slide is the tumor component, which is the adenocarcinoma. Now, so once again, there are also some, in this diagram also there are some glands. They also look very much like the glands that we have seen previously, like intestinal glands. So these are also glands. So now there is one round like this. So now there is a round, and this round is surrounded by all these glands that we talked about. Now what do you think this might be? So we are talking about intestine, and we're saying this round doesn't look very big, right? So normally a whole intestine, the cut section will not come in a very small slide. So this structure must be very small. Now you tell me, what is the small structure that is there in the intestine? Can it be appendix? So this is appendix. This is appendix, which is also containing these glands, and it has a lumen which is very narrow because vermiform appendix, right? Appendix is a very small thing. So when you do a cut section, the round will be small enough to fit a single slide. So that is what it is, and you can confirm this by seeing the lymphoid follicles. So these blue looking things are the lymphoid follicles which you normally see in an appendix. So this would be appendix, and whenever you see appendix, the answer of this question would be acute appendicitis. Or it is, I think, also in the given thing, it is given as cells of acute inflammation. So what are the cells of acute inflammation? They are neutrophils. Even though you don't see neutrophils from a very low power as here, when they focus this, they'll actually put so that you can make out that this is the appendix. And when you see the appendix in the exam, blindly write it is acute appendicitis, and write in the bracket cells of acute inflammation, which is the neutrophil. Now, since we finished acute inflammation, we also have a slide which says chronic inflammation. Now, once again, we find similar glands that we see in the intestine, etc. So this structure, I know it is a little hard, but please remember this as gallbladder. So when you get appendix, you write acute appendicitis, which is acute inflammation, neutrophils. When you get gallbladder, please write it as chronic inflammation, which is lymphocytes. You can actually see some lymphocytes here. All these blue dots are all lymphocytes. So one thing you can recognize gallbladder is, what are the four layers normally? You have mucosa. This is the mucosa. You have submucosa, you have the muscularis and you have the serosa. So here can you see this is all muscle. This is all muscle here. So all these muscle bundles are going, like we previously saw some other soft tissue as well. There is a lot of muscles which are there. But mucosa is here, muscularis is here. What about the submucosa? So one thing to diagnose C gallbladder is that gallbladder, it lacks a submucosa. It doesn't have a submucosa. It only has mucosa, then followed by muscularis and serosa. It only has 3 layers, unlike the 4 layers seen in other parts of the GI. It doesn't have a submucosa. That is how you see that this is a gallbladder. And whenever you see the gallbladder, please write it as chronic cholecystitis. And in the bracket you write cells of chronic inflammation, and the cells of chronic inflammation are lymphocytes. Cells of acute inflammation are neutrophils, cells of chronic inflammation are lymphocytes. So the answer for this is chronic cholecystitis, which is cells of chronic inflammation. So now number 17, once again we see some glands which kind of look similar, but in the middle we have all these blue things. So what are these blue things with the glands which are like this? So this is endometrium. Endometrium, and endometrium contains the glands. Number one, that we see all these glands are endometrial glands, and these blue looking things are actually the stroma. They are not lymphocytes, but rather they are the stroma of the endometrium. The stroma are like this. They are like these blue dots are all the stroma that are there. And here we can see that the stroma are very close to each other. They are compact, we call it. This stroma is called as compact, and the glands are usually just round, small gland tubular like that. So this phase of the endometrium, when normally everyone knows, I think, that endometrium has 2 phases in the menstrual period. One is the proliferative phase and one is the secretory phase. Where proliferative phase is done by the estrogen, whereas secretory phase is taken up by progesterone. So this part where you see round tubular glands and you see very tightly packed stroma, it is looking very blue, right? So that means it is tightly packed, and this is called as proliferative phase. So in proliferative phase of endometrium, you see round tubular glands and you see compact stroma. That is the word we use. We call it compact stroma because the stroma is very close to each other. I mean, that's why it is densely packed kind of. That is why it is looking very blue, and that is why it is called as proliferative phase of endometrium, which contains compact stroma. So now if we have finished proliferative, we should also have secretory. So let's go and see how secretory looks like. So secretory looks like this. So once again, if you see the stroma, you can see now when compared to the previous thing, this stroma is actually much apart from each other. You can see a lot of white spaces in the middle. So this is called as edematous stroma. So in proliferative phase, we told that the stroma is compact, whereas here we see edematous stroma because there is a lot of edema in between. That is why the stroma are not compact anymore. They are loosely packed, and this is called as edematous stroma. And also the glands itself sometimes can be tortuous, they can be enlarged, and very classically you can see all these little bubbles, right? So these bubbles are actually mucin. They have apical mucin, what is called mucin. So these glands, these epithelial cells which show mucin, but don't worry about it. This diagram, actually the secretory phase slide is not that great. I think I tried to take a picture and I saw something like this. But please remember, these are some, there are some glands here, here. But the stroma is not exactly compactly packed. They are widely packed. There is some space between them. So the 18 would be secretory phase of endometrium. So once again, apart from granulation tissue, please pray that you don't get secretory phase, because in this slide, I think it is not that great. I don't know if there is another slide for the exam, but if you see another slide, you can see there is displacement of the stroma that is there apart from each other. So that would be the secretory phase of the endometrium. Now moving on to the next slide. So at 19, so can we see here, I think it's a little difficult once you look at it, but we'll try to make out what is this slide and we'll try to talk about what is this. So now if you can see inside, I mean, you have to look a little closer, I think, because the clarity is not that great. But can you see these cells which are like spindles? They're like a bundle of spindles, like almost like a group of cables which are going. All these things, they're not exactly round or they're like this, but rather they're spindle shaped. So this is a spindle cell tumor, and this tumor is actually related to the muscle. So I'll just show you a better image. Say all these muscle fibers, they are spindle shaped and they're going like this. So the diagnosis of this would be leiomyoma. It's a very common tumor that you see in your uterus. So leiomyoma is that. So leiomyoma, oma is a benign tumor. Myo means it is muscle. Leo is smooth muscle. So it is a tumor of smooth muscle. It is called as leiomyoma, wherein you see a lot of fascicles. Fascicles means that bundles of this smooth muscle, the spindle cell smooth muscle, which is going in different, they're going in this direction. It is called as leiomyoma. Now, there are 2 slides which are related to leiomyoma. One is leiomyoma itself, and other one just in a while I'll just come to that. Now I'll just draw once again. I'll draw how leiomyoma looks like. So these are all spindle shaped cells which are going. So let's say we'll just draw some 9 cells. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Now these are all spindle cells. I told you they're like a bundle, like a cable, like a bundles in a cable. So all the different fibers are going in this. So now when you have leiomyoma for a long time, there are some changes which can happen. So one such change is called as hyaline degeneration. When you have a long-term leiomyoma and the patient has not gotten operated, there can be some benign change itself. It is called as hyaline degeneration, wherein the cells secrete a lot of pink material. The cells secrete a lot of pink material. Now let's imagine once again. Let's just take 3 cells. They're like this. Now they are secreting this pink material which is called as hyaline. This hyaline material. Let's imagine that it is like water. Now if it is secreting something like water like this pink material, what will happen to the gap in between these cells? As I secrete this thing, the secretion will actually try to fill the space and it will push these cells apart. So previously they were very close, but now because of the secretion of hyaline, they have been separated from each other. So this is called as hyaline degeneration, and this pink amorphous matrix, it is called as hyaline degeneration. Now we'll see how this hyaline degeneration looks like. So our slide is not very proper, but you can see when you compare it to leiomyoma, you can see it is much paler, and it is paler because the cells are widely spaced from each other. So you can see nice spindle shaped cells here, nice spindle shaped cells here, nice spindle shape. They're not very close to each other, but rather they're apart from each other, and that is why. And in the middle, it is filled with this pink glassy material, and this material is called as hyaline degeneration. So if you write this question as leiomyoma, they'll give you some marks, but the idea is if you write hyaline degeneration of leiomyoma, you'll get the full marks. So there are 2 slides related to leiomyoma itself and hyaline degeneration of leiomyoma. What you should see for the spindle cells, and there is gap in between the spindle cells. If you see a lot of pink, then it becomes hyaline degeneration of leiomyoma. So once again, this is one diagram which is showing from outside, which is this is the spindle cells, and in the middle you can see a lot of pink, and this pink is actually the hyaline degeneration. Moving on, 21. I think this is one of the most easiest slides as well. I think I'll place it right after lipoma, and you can see one tissue, some tissue is there, and you can see a lot of these rounds, and inside these rounds you see a lot of dots, right? So a lot of dots. Let's say these big rounds and a lot of dots. So what is the diagnosis? If you're thinking rhinosporidiosis, you are absolutely right. So this diagnosis is rhinosporidiosis, and these round things are all sporangia which are containing the spores. Another close-up diagram, if you can see, we can see the sporangia which are showing the spores, and you have a lot of inflammatory cells because it's an infection. Your body will try to fight with inflammation, and especially a lot of eosinophils sometimes you can see in rhinosporidiosis. So now slide number 22. So this is a little hard if you look at directly from here. You can see a lot of tumor cells. These are all tumor cells, tumor cells, and there are some gaps in between them. So anyway, all these tumor cells, the answer for this is dysgerminoma. Dysgerminoma, which are a tumor of germ cell tumor. It's a germ cell tumor of the ovary, which is called as dysgerminoma. In the males, if the same tumor happens, we call it seminoma. But in our exam, please write it as dysgerminoma. And in dysgerminoma, we can see tumor cells. They are a little bigger than the lymphocytes, and they are sheets of this tumor cells. I'll just show another version of this as well from our slide itself, which is a 40x, which is a high power thing. You can see the cells, all these tumor cells, and they have a classic appearance which is called as a fried egg appearance, because the cytoplasm will form a little layer outside the nucleus. Okay, so it is a little irregular, and that is why it is called as a fried egg appearance. Okay, you can see some little this fibrous strands as well. These are called as septa. So you have tumor cells, which are sheets of tumor cells, which have the septa, which are divided, and you see a lot of lymphocytes. This lymphocyte thing also you can write that there is lymphocytic infiltration, which is classically seen with dysgerminoma or seminoma. So you have tumor cells which are showing fried egg appearance. You can see lymphocytes, and they are separated by thin fibrous septa. So this would be dysgerminoma. Now, before I talk about the next slide, I just want to make sure that there is one slide which is called hydatidiform mole. So that is the slide. So for this to understand, we know that in the placenta, when the baby is forming, you have something called as a chorionic villi. Chorionic villi, whatever it is a finger-like projection. So normally you have finger-like projection, and then you have syncytiotrophoblasts and cytotrophoblasts, which are the ones which are actually pulling the maternal nutrients from the circulation, from the maternal circulation. So now in hydatidiform mole, You know that they look something like this, grape-like vesicles you must have studied. Now what are these grape-like vesicles? One change which happens in hydrated mole is called as hydropic degeneration. So what is the meaning of hydropic degeneration? Hydropic degeneration stands for there is water which is coming into the villi. So normally if a villi is like this, the villi of hydrated mole will become very much enlarged like this because it is getting filled with water. That is why it is called as hydropic degeneration, and these villi only will form this grape-like vesicles. So this change is called as hydropic degeneration. So this finger-like projections like this, they became like this filled with water. It is called as hydropic degeneration. So I'll just show you a slide as well. So now you see this. There is a lot of hemorrhage. Obviously, they're trying to invade the maternal vessels. So a lot of hemorrhage usually is there. But do you see this finger-like projection? Do you see this very big finger-like projection is completely white almost in the middle because all this is water. All this is hydropic degeneration. So this huge thing which is there in the middle, it is the hydropic degeneration, and the diagnosis of this would be a hydatidiform mole. It's a partial mole in the exam. I mean partial mole, complete mole, forget all that. But please write the answer as hydatidiform mole. You can also write it as vesicular mole. So in the exam when you write hydropic degeneration is seen. Hydropic degeneration of the villi is seen. So this is one villi. Villi are normally not this stout, but here they are very big because there is hydropic degeneration. So we have finished the histo slides. So pat yourself on the back if you have made it this far into the video. So I'll talk about hematology just in a while, but before I talk about hematology, I just want to make some common points and then we'll talk about what are the slides which are there in the exam. There are only about 6 slides I think for hematology. We'll go through all of them. It's not that hard. We'll just go through them as so. So now in the blood there are 3 types of cells. So one is the RBC. So here we have an RBC. We have WBCs. So this is a neutrophil, right? So we have some 4 neutrophils here, and this is the platelets. So you have RBC, you have WBC, you have platelet. Now for your exams there is nothing related to platelets. It's either RBC or WBC. So we'll just focus on these 2 things. So now I want you to think about this. RBC. What is the normal count of RBC that you see in an adult male? It is about 4 million to 5 million. Yes, so what is 4 million to 5 million? 40 to 50 lakhs. Right? So what about WBC? The normal WBC count is 4,000 to 11,000 per cubic millimeter. So 4,000 to 11,000. So they are considerably very less when compared to the RBC. So that has been reflected here in a normal peripheral smear. That is, we can see RBC, many RBCs, but we are only seeing less WBC. So because they are only 4,000 to 11,000 when compared to 40 to 50 lakhs of RBC that we see. So they're almost like 100 times more when compared to the WBC. So that's why in a smear when you see, you should see more RBC and you should see less WBC. And if you see more proportion of WBC, that means WBCs have been increased when compared to the RBC. We'll see that just in a while, but please remember that. So point 1 is RBC should be much more than WBC. So number 2 is one more thing is when you see the RBC. So what do you see inside the RBC? When you see like this, you can see a little white space in the middle. There's white space. So this white space is called as a central paler because you know that RBCs are not normally round, they are biconcave shape. You must have studied. They have this biconcave shape. So if they are biconcave shape, in the middle there is less hemoglobin. So because of that, in the middle, when you see under, when this is 2D picture of the RBC, so they'll have some white space in the middle. And usually the central paler is not greater than 1/3. So 1/3 of the size of the RBC. So if you see this is the RBC and the paler is not 1/3 when compared to the diameter of the RBC. So this is a normocytic RBC. So as we talked about earlier, then we'll go to some diseases and we'll talk about them. So now the first thing. So the first thing you have to see here is in hematology. Now once again, compare how many RBCs are there, compare how many WBCs are there. See, RBCs are these pink things, they don't have a nucleus. Whereas in this thing, when you compare with before, there are lot more WBC, so many WBC. I mean, in the slide, it is looking like there are more WBC when compared to the RBC, which is usually not the case. But we can see that there is overwhelming amount of WBC which are there. So normally WBC should be less. So if there are so much, I think this WBC should be in lakhs. They are not in thousands, but in lakhs. So can you tell me one condition where there are in lakhs? It is leukemia. So what type of leukemia is this? We'll see. We are seeing a neutrophil, we are seeing all these things. I mean, this answer for this is chronic myelogenous leukemia. Because in acute leukemia, you see blasts. We are not seeing blast here. Rather, we are seeing little mature cells. We are seeing neutrophils. Don't worry. If you see this many things, it is CML, which is chronic myelogenous leukemia. And one of the things which are classically stands out in CML is basophilia. So can you see this cell here, right here? This cell, this little cell. This cell contains, I'll draw this cell as well, this cell as well, this cell as well. It has some bluish granules, this cell, bluish granules. So what are these cells? They are basophils. And basophilia is seen with CML, that is. So we see basophils and you see a lot of cells. It is in lakhs, so it is leukemia, and you can say based on the presence of these basophils, we call it CML. So answer of this question is CML. So now let's go to the next slide as well. So here also, even though the cells are not, WBC are not as increased as we seen before, here also we can see they are very much increased. Maybe not as much as before, but obviously like when you compare to the first slide, there were only 4 WBC, but here there are a lot of WBC. Now, I want you to focus on these things. See this WBC, see this WBC. Can you see there are something like this? The nucleus is something like this. So if you take this nucleus, there are some little punched out holes into the nucleus. So what are these punched out holes? If you're thinking that these are nucleoli, you are right. So these are actually nucleoli. So this is the nucleus, the whole thing, and inside the nucleus you have nucleoli. So which cells do you see a very prominent nucleolus? So the answer of this would be a blast. So these are all blasts, and the blasts which show very prominent nucleoli are myeloblasts. In lymphoblast also you can see the nucleoli, but they're not as predominant as we see here in this peripheral smear, which is you can see very nicely punched out holes which are the nucleoli. And this answer of myeloblast, when you get myeloblast, the answer is AML, which is acute myeloblastic leukemia, because you see a lot of myeloblasts. So you have CML, which shows a lot of cells, and AML, wherein there are a lot of cells as well, but these cells, they are classically showing this punched out holes, and there is no basophilia here. You don't see any basophilia here. So the answer of this would be acute myeloblastic leukemia. So now this is also, I think I'll put this number 2 or 3. It is one of the easiest slide. So you can see all the RBC here. These are all RBC, and you see an organism here. So what is this organism? Very classically, I think everyone will answer. The answer is microfilaria. So microfilaria is the filarial larva which come into this, and that we can diagnose under the microscope. So it is caused by Buccaria bancrofti. So that is microfilaria. Moving on, 27. So what is this cell? I think you've studied in physiology as well, so I'll not spend much time here. There are 2 lobes, and you have very pinkish granules. So this would be eosinophil. So you see in the exam as well, you'll get a slide of eosinophilia. You may get a slide of eosinophilia. So this is eosinophilia. So if you see 2-3 eosinophils, they'll usually focus in a field where there are 2-3 eosinophils. So make it out by seeing the 2 lobes, and you see this eosinophilic granules inside. So the answer would be eosinophilia. Now I finished all the slides which are there, but there are 2 more bonus slides which may be put for the exam because they have been put for the hematology slide. So I'll just discuss them here. So now let us look at the RBC here. Do you think the RBC count and all, when comparatively WBC, it's all okay? But now let us look at the RBC. What did I tell you about the paler? When I told you about the paler, I told you that normally it should be less than 1/3. The white thing. But see this, we'll take this RBC outside. See how much is the paler? Almost more than 2/3. So it is completely white. This is also completely white. This is also completely white. Now where do we see increased paler? What do we call this condition? We call it hypochromic, because it has less red in it. So that is why it is hypochromic. Now what is the size of the RBC? How do we see the size of the RBC? We compare it to the nucleus of the lymphocyte. So we have conveniently a lymphocyte here. When we see this lymphocyte and when we compare to the size of the RBC are smaller. So this diagnosis is microcytic hypochromic anemia, which is commonly seen with iron deficiency. So the answer of this would be microcytic hypochromic anemia, wherein the RBC are smaller and they have increased paler as well. So microcytic hypochromic, microcytic because they are small, hypochromic because the paler is increased. They are less colored, so that is why the paler is increased. The whiteness of the RBC is increased. The last slide of the day, which is the contrast of microcytic anemia. Now, once again, we conveniently have a lymphocyte here. Now, can you see these cells when compared to the size of the lymphocyte? They're much bigger, much bigger. So the diagnosis of this would be macrocytic anemia. So macrocytic anemia. the diagnosis of this because they are larger than the nucleus of the lymphocyte. And one or more, you commonly see it with B12 deficiency or folate deficiency. And commonly you see another cell here which is called as a hypersegmented neutrophil. Even though this is not there, I'm just mentioning that. So that is macrocytic anemia. Now, if you have come this far, let's quickly go through, let's diagnose, right? So I'll give you 5 seconds for each slide. So you see this slide, what is this? It is fatty liver, because you see a lot of fat, but these are not like adipocytes, they are little smaller and there is a lot of pink. So the answer of this slide is fatty liver. Now this one. There is a lot of blood inside and these are big vascular channels, so the diagnosis would be cavernous hemangioma. Okay, this one, very classic. The answer is pleomorphic adenoma. Because the left side we discussed, this is all the salivary gland. On the right side we have chondromyxoid stroma, which is pleomorphic adenoma of the salivary gland. Now what about this? The easiest slide of all, it is lipoma. Because we see adipocytes which are containing all this big. What about this? It is granulation tissue. Okay, because we talked about small blood vessels and there is a lot of lymphocytes and there are also fibroblasts. So this is granulation tissue. Now what about this? You should get this. There are a lot of small things and they all contain blood. Some blood is there, some RBC are there. So this is capillary hemangioma. Now what about this? Just focus on it. Focus on the see the things clearly. You will find the answer. What about this? This is a keratin pearl. So keratin pearls are seen where? In squamous cell carcinoma. So the answer of this slide is squamous cell carcinoma. What about this? So in this blood vessel, we are seeing in the medial layer, we are seeing a lot of this deposition of calcium. So this diagnosis would be Monckeberg medial arteriosclerosis. What about this? As we talked about earlier, you are seeing normal round glands and you are also seeing these compressed ducts which are called as intracanalicular patterns. So the diagnosis would be fibroadenoma of the breast. Moving on, one more classic. So this is caseous necrosis or chronic granulomatous lymphadenitis, which is seen with tuberculosis. So caseous necrosis, that is the pink areas, and in the middle you have the blue areas. What is this? Once again, nice blue things are there, very classic. It is basal cell carcinoma, retraction artifact and peripheral palisading. What about this? This is proliferative phase of endometrium, round glands and compact stroma. What about this? You are seeing muscle bundles which don't have nuclei. So this is myocardial infarction, which is an example of coagulative necrosis. Which is the hallmark of coagulative necrosis is loss of nuclei, but the cell borders are maintained. So again, still till that this is tumor. I mean, this is not tumor, but rather this is muscle bundle, and there is no nucleus inside. What about this? This is appendix. So the answer of this would be acute appendicitis or cells of acute inflammation, which is neutrophil. What about this? So this is all the epithelium which is there, and inside you see a tumor, and the tumor shows brown pigment. So the answer of this would be a malignant melanoma. What about this? We see glands, all the mucous glands, and here we see the tumor. So this is adenocarcinoma of the colon. What about this? We are seeing some glands, some stroma as well, and the stroma is not very compactly packed, it's rather loose. So this would be secretory phase of the endometrium. What about this? So once again, this is having spindle cells which are arranged in fascicles like bundles, bundles, bundles. They're going like this. So the answer of this would be leiomyoma, which is the benign tumor of smooth muscle of the uterus of the myometrium. What about this? This is also smooth muscle again. These bundles, but they are much separated from each other. So this is hyaline change of the leiomyoma, hyaline degeneration or hyaline change of leiomyoma. What about this? So once again, we can see a large chorionic villi which is filled with fluid, filled with water. This is called as hydropic degeneration, and the answer of this would be a vesicular mole. What about this? The answer of this would be dysgerminoma. Fried egg cells which are separated by septa, and you have some lymphocytes. So this is dysgerminoma. What about this hemat slide? This is acute myeloid leukemia because you see a lot of blasts, and how do you classify blasts? They're big cells which have punched out nucleoli. Very prominent nucleoli can be seen. So this is a myeloblast, and the answer of this would be an AML. What about this? This would be an eosinophil. So the answer of this would be eosinophilia. What about this? I think everyone already got it. It is microfilaria. What about this? Also an easy slide. It is rhinosporidiosis, which is having the sporangia which contains spores. All these are sporangia. So the last slide of the day. The answer of this is, there are so many WBC, and you see very importantly this granulocytes which contain this basophilic granules, and these cells are basophils. The answer will be CML, which is chronic myelogenous leukemia, and the count here is very much in the lakhs itself. Right, so that will end the discussion of the slides. I hope this was kind of just a confident booster before the exam. So all the best for your exams, and I hope you all get very good marks, so that this marks also will be added to your theory exam. And even though some disturbances are there in theory, maybe you can actually use this marks and try to pass pathology and get rid of the second year and go into the third year into your clinical years. So all the best, and good luck again.